are doing desensitization. But again, there is challenges to even this beautiful methodology, panel constraints as well, especially as Maha mentioned, there is close to 7,000 different alleles. There is no way for 100 beads to carry that many alleles. So they choose the most common ones. We might have some common antigens or allele that's not common in North America, for example, and we buy kits from there, we might be missing it. Hopefully not. Big challenge with the solid phase immunoassay is false positive with non-native epitopes, which means when you put the HLA molecule on the beads, you are attaching it physically. So this might affect the conformational structure of the molecule, which lead either to false positive or false negative. Also, variable amount of targets. The beads are coated not with one antigen, as I mentioned here, or I showed for simplicity, coated with, say, 40 to 50,000 different HLA molecule, but not each single antigen carrying the same level of HLA molecules, which might be really tricky for someone who is not really expert, especially when you are monitoring for change in antibody MFI. Also, it can have challenge with non-specific binding. One drawback about it, many people think it is too sensitive, which means when you send to us a sample in the lab, we say he is sensitized, and when you do transplant him, despite our word that he is sensitized, the kidney will be doing fine, no problem at all. But that doesn't mean it is really safe. The immune system, once the patient really become flexible with his medication, this really might be bad for him. This low titer will become really bad for him. Also, there is challenging to the specimen itself when we receive. Some patient has they have high level of IgM in their serum, which will really interfere with the detection system. There is a way to solve it. I will not talk about it here. Also, if there is antibodies in the patient's serum to the beads itself, not to the antigen on the beads, that will give you high background and some complication. Also, if you have some therapeutic antibodies, will interfere with this result. We are equipped in the lab to deal with these challenges. So the use of solid phase immunoassays really increase the transplantation rate, especially for sensitized patient. Rapid and accurate post-transplant monitoring, which also help confirming any expected AMR. And if we predict that there is AMR, with using the single antigen, preemptive treatment can be initiated. Of course, the beauty of it in supporting of the sensitization programs, which we have one very busy one at our institution. Also, it will equip the lab to do virtual cross-matching, which is something Fadi will be talking about in the next presentation. I will skip these slides, although they are important, but due to the time. Final thing I want to mention that, again, HLA antibody testing can be qualitative or quantitative, which help in the assessment of alloimmunization in transplanting patients. I will move to the last one. It's very important to use an antibody detection method that in sensitivity it's very close to your cross-match sensitivity. So if you use something less, you will say he's non-sensitized. When you do cross-match, it will be positive. Or when you use too sensitive of an antibody detection method and your cross-match is not very sensitive, you will have the cross-match negative PRA, which will give vague picture to the treating physician. I will conclude by thanking the histocompatibility and immunogenetic laboratory staff, and thank you all too.
Thank you very much, Muhib. Now, as they say, save the best till last. Many of you know Muhib as the very dynamic person in our HLA lab, like many of the people we have there. He will conclude the didactic session by presenting on the crossmatch. Fadi. And he would try to save as much time as possible for the questions. We were a bit late, so I think we'll have about 15 minutes to 20 minutes for questions.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum jami'an wa rahmatullah. Good morning, ladies and gentlemen. I think they make it very difficult for me to speak after my colleagues. Today I'm going to talk about the cross-matching as a success factor in renal transplantation, and I will elaborate on how does the clinician look at this from the clinical side, and how does the laboratory people could interpret their results precisely and in a timely manner. In order to assess a kidney transplant pre-transplantation, there are multiple technology or methodology that has been since decades applied in a laboratory. One of them is, as probably Maha mentioned, HLA typing, that can use two crucial components of the body, which is DNA or cell. And the other thing is cross-matching, which is using two different methodology, which is either flow cytometry, cross-match, or complement-dependent cytotoxicity, which I'm going to go in details and talk about it. And the other one is the techniques that Dr. Muhib talked about, which is the HLA-specific antibody, and there are different methodology applied in the laboratories to assess those. All of these three is the component and play a major role in order to assist the patient prior transplantation. Not only that, even though post-transplantation, sometimes some of these techniques should be implemented in the laboratory. So cross-matching, basically, it is in vitro transplantation between the patients with end-stage organ disease and his donor. So basically, it is a transplant, but in the lab, in which we would like to know, as people in the laboratory, is this patient has any antibody that will be able to recognize that antigens of the donor. So we are testing before they cut the patients, before they bud the graft. We would like to know how does that immune response will react to that organ. So this techniques basically, and this is type of the lymphocyte that express HLA molecule, and we would like to see is this antibody that you see in the slide will bind to this or not. There are different methodology has been applied in the laboratory. Complement-dependent cytotoxicity, which is down here, and then HG-CDC crossmatch, and the last is flow cytometry. As we go up in this slides, the sensitivity and specificity of the methodology go up. You might still ask if the flow cytometry crossmatch is still very sensitive, as say, why does the laboratory must do CDC or HG-CDC? Because every methodology has its own language, and certain information from every methodology we can get. CDC, yes, it is low sensitive. Yes, it is less specific, but still the information that we can get from this type of methodology might really impact on the physician decisions, how he going to treat that patient, if he going to transplant or deny the transplant. So every one of these assay has its own language. Starting, and this slide has been shown from my colleagues before, even example, if the patient has anti-A2 antibody, and if we have his donor has A2 antigen, then definitely this antibody will bind to that antigen. And then we add the complement. This complement will fix that antibody, and then we'll have a cell lysis. But this methodology is a CDC. This can be happen only if that antibody fixing complement, and also if that antibody is very strong. In which, probably you saw these slides many times, but I will look at it from different perspective, which is, If you look here, there is 24 people here. Example with positive cross-match has a rejection, and here 187 with negative cross-match has no rejection. But what about those group that has positive cross-match, no rejection, and negative cross-match with rejection? So there is two things that we have to look at, which is relevancy and sensitivity. Of course, those patients that have negative cross-match and the rejection, probably that method that applied in that laboratory were not sensitive enough to pick up low titer antibody. So if you depend on CDC cross-match to transplant your patient, but in your mind that you might still see AMR rejection post-transplant due to the method that you applied in a laboratory, so this one trigger you to apply very sensitive assay in order to avoid any AMR episodes. On the other hand, the relevancy. Not every positive cross-match is really relevant. So we have to understand then what is relevant. Is every positive cross-match we can deny transplant? No. Is every positive cross-match we can transplant? Still, it's debatable, which I'm going to go on about it. Now, we have to understand what is relevant. In order to understand what is relevant, it must be HLA-specific antibody. So positive cross-match with no antibody need to be really look at it carefully. And another thing, it should be donor reactive. If there is no donor specific antibody and positive cross-match, there is things doesn't make sense, have to be also looked at and interpreted carefully. IgG antibody, the type of the antibody. If it's IgM, there is a contraindication about this this positivity. If it's IgM, might not be contraindication to transplant. So we need to look at these things: HLA specific, donor reactive, and IgG antibody. Those are the three factors that can say a relevance. CDC, as I mentioned, it is least sensitive assay, but can detect only high titer antibody. So if the patient with low titer antibody cannot be detected. If the patient has antibody with doesn't fix complement, you might say it is negative. Once they put a graft, the immune system will be activated and AMR episodes will be appear. So this one we cannot depend on as a safeguard to transplant a patient. That's why now most of the people at least implement HG-CDC crossmatch. HG stands for anti-human globulin. This is to enhance their positivity. This is at least steps over the primary or the basic methodology, which is the CDC. This is example as you see in the slides here, which is the donor T lymphocytes. And when we add antibody, it will bind. But remember, if this antibody doesn't fix complement, without using HG, you might not be able to detect it. If this antibody is very weak antibody, you might not be detected. So that's why now we implement HG. HG is anti-human globulin that will bind to the primary antibody that is already bind to the primary one, which is this one, and then once we add the complement, definitely it will make a network here and will kill the cells, and then it will enable us to detect this positivity. Many studies going around, I don't have to go through this, but CDC, as you see in this slide, CDC versus HG, they did 32 out of 166 detected positive. When they implement HG, they detect more positivity. So at least this is a little bit methodology over than the basic methodology. So from the CDC perspective, what is the decision that we as a laboratory could take? Is it negative cross-match, can we proceed? No. It is basically negative cross-match. It cannot tell us to proceed to transplant, but positive cross-match of CDC can rule out more than to proceed. But this is not a safeguard to implement it as a final decision. Flow cytometry is very sensitive assay. And from its name, flow is something that flow is continuous movement, cytometry measurement, so measurement of continuously moving cells. That means basically, and I'm sorry for the people who work in the flow cytometry might not be a science by itself, but it could be an instrument apply, and we use that technology. So it is. Now we are measuring that cell that passes through a laser, and we will identify that cells what antibody bind to that cells. Sorry, I have to go back in this. Okay, cell specificity. There is still advantage and disadvantage of a flow cytometric cross-match. One of the things is, we are cross-matching mainly lymphocyte, T cell and B cell. Why? Because those type of the cells is the responsible to accept or reject the graft mainly. This is one thing, and in addition, they express lymphocytes, and those lymphocytes is the first antigen going to be recognized by the immune system once they put anastomosis when they put the graft. So one of the issues here is T lymphocytes is express HLA antigens most likely, but the B lymphocyte is the jungle cells express HLA and non-HLA. What happened in the flow cross-match, you might still face challenge in which you might see patient's antibody, or there is patient's antibody might not bind to the HLA antigens. So you have to remove all of the stuff, all of the jungle, and keep only HLA. That will improve your sensitivity, that you will make you sure you are dealing real with HLA. And to reach this step, you have probably recommended to use pronase as enzyme. Pronase try to block some other receptors, at least, without going in details, and they will enable us increase the sensitivity to target only HLA. That is our focus. We isolate donor cells and we mix it with patient serum, and we mark the B cell with CD19 that has a fluorochrome or color, and CD3 which is a marker for T lymphocytes that also mix with the color, and then we add a secondary antibody that will bind to the primary antibody. Then we will be able to detect it. Without going in details of how we interpret the techniques, at least in the lab, but the unit of interpretation is a channel shift. So we have a negative control tube here, and that we interpret it by channel shift. So 40 channel and more could be positive. And by the way, this 40 channel, probably 40 channel at our laboratory, another laboratory 60, another laboratory 80. So every laboratory should do their homework to establish their cutoff. And more than 40 channel, it tell you that this example positive. And then as much as you have channels, 100, 200, 300, as much as you have more channels, as much as this cross-match is very, very strong. One of the issues also in the flow cytometry cross-match is the challenges. You cannot differentiate if it's positive. Example, if you see positive cross-match, is that positivity due to complement fixing to antibody or not? It cannot tell you. Still there are the debates of the people, is the complement fixing antibody is the only important antibody? Probably this is in debates, and a lot of people talk about it without going in details of these, but this technology cannot tell you. It tell you only positive or negative regardless of complement fixing. In the other hand, therapeutic effect, those physicians or clinicians who treat the patient pre-transplant, example, giving them rituximab or IVIG, both of those factors, the lab people should be really careful and look at it very carefully. If the patients receive rituximab, then put in your mind that B lymphocyte is inconclusive, because rituximab will bind definitely with the B cells. So you have that once the patient gets rituximab, the interpretation will be useless, especially for the B cells. And IVIG, if the physician desensitize the patients, or if the physician give IVIG as a treatment to remove such antibodies, perform a cross-match post IVIG, it will be inconclusive, because you are not sure, are you cross-matching the IVIG itself, or you are cross-matching the patient's antibody? So knowing both of those factors is really crucial. And if you interpret a cross-match and it's positive, you make it a contraindication, and he is under this treatment, it might not be a proper decision. Now, if we have a positive cross-match, you are in the clinic or the people in the lab, how you interpret these? There are different questions. If you ask yourself about it, you will be able to interpret the cross-match properly. If you have a positive cross-match, you need to ask yourself, against which type of cells? Is it T cells or B cells? Examples, if it's T cells and B cells, then there is definitely you should see antibody against class 1 and class 2. Impossible to interpret a cross-match without knowing the sensitization or without knowing the antibody profile of the patients. Example, if you have a positive T cell and B cell, and the patient don't have any even a class 1 antibody, by very sensitive assay, doesn't make sense. So you need to look at it carefully. Another thing, if you have a positive cross-match against B cell only and the T cell negative, what does that mean? That means probably the patient have class 1 low titer because T cell is negative, and as we all know that T and B cell expressed class 1. Since the T cell is negative and the B cell is positive, there is two options in this scenario in which either the patient have low titer class 1 antibody or class 2. Then also the lab people should look to the antibody profile and interpret the result properly. If you have a case that positive T cell and negative T cell, is this possible? That's not logic, because probably not due to HLA antibody, because HLA expressing T cell and B cell. Since the B cell is negative, doesn't make sense to see it negative, right? Doesn't make sense. It should be positive if it's due to HLA. So most probably this phenomena with positive T, negative B is not due to HLA antibody. It might not be contraindication to transplantation. Another questions now, if you have a positive cross-match, now you need to ask yourself, is the patient sensitized? If yes or no. If no, now, and the positive cross-match doesn't make sense now a little bit. You need to ask yourself, is the patient has autoimmune disease? Does the patient has SLA? If he has SLA, which is autoimmune disease, then the positive cross-match is due to auto disease that he has, not due to HLA. Can we transplant the patient? Yes, definitely we can transplant that patient because that positivity not due to HLA antibody. Now, if it's positive now, and the patient is sensitized, you need to look, does he has class 1 or class 2? If yes, he is sensitized, you need to look for donor-specific antibody, because all of us know not every patient sensitized might lead to positive cross-match. Then another thing, in the other hand, if you have a positive cross-match, what is the last questions you might ask yourself is, what is the antibody isotype? If you are dealing with IgM, you are totally in different direction. If you are talking about this positivity due to IgG, here that we need really to focus about this interpretation, and it could be definitely contraindication to transplantation. Now, to come to this slides is, if you have a positive cross-match and you know against T cell and B cell and you know that this is donor-specific antibody, but still we need to understand what was the methodology applied. This result of positive cross-match, was it due to inflow or CDC? Because every one of these tell us certain language, certain information. Now, if the methodology or the positivity due to CDC cross-match, then you are talking is very high titer antibody. Maybe giving the clinician this information, maybe he will deny the donor and completely go different direction. But if you tell him that this positivity is due to only flow cross-match, he might use his tools and weapons of like IVIG, desensitization, and transplant the patients. So giving the clinician full information, the methodology, which type of cells might help him to decide what he need to give as induction immunosuppression and or desensitization methodology. Now, this is a lot of people mix of two different things. What make CDC positive should be definitely high titer antibody. Since most of the laboratory worldwide now mostly implement solid phase assay by Luminex, depending on MFI, which is median fluorescent intensity. A lot of people thinking that MFI is a titer, as probably I'm sure as Dr. Muhib mentioned, MFI is not a titer. It is a fluorescent. So we try to, and every laboratory must establish their cutoff, in which when they say to us very high MFI, it will lead to CDC. We showed completely different things, as you see in this slide. We try to bring like most of the prestigious laboratory worldwide, like Mayo Clinic or John Hopkins, thinking that more than 10,000 MFI will lead to positive CDC, and our observation here is different. If you look more than between 0 to 10,000, which is not that high, we see still negative. But once you go also more than 10,000, still you see a lot of negative CDC cross-match. So depending on MFI as a titer might mislead you in the laboratory, okay, to decide is this strength will cause CDC or not. So MFI is mandatory, is a number. Yes, it is. We have to respect that number as high or no, but we cannot depend that this patient definitely more than 10,000 or 15,000 MFI will lead to positive cross-match CDC. Now about the flow, we find more relationship between channel shift of the flow cross-match and TCDC. We test in our institution, we test the patient who have more than 250 channel shift. We see most of those has a positive CDC. However, less than that is less, and the correlation is 0.9, which is very high. So this one, I think it will guide the lab, and it will give the lab a little bit a clue where to go and expect how the cross-match will be showing before you perform it. There are 4 paradigms in the interpretation of antibody and cross-match. If there is antibody negative, most likely the cross-match will be negative. If there is antibody positive, most likely the cross-match will be positive. If it's a DSA, this is a little bit more easy and straightforward. But what if you need to consider if the patient don't have any antibody and the cross-match is positive? This one need to look at it carefully. This cross-match is irrelevant, or probably the patient has autoimmune disease, as I discussed earlier. On the other hand, if you have a patient who is sensitized, still we cannot deny a patient from transplantation if he is sensitized, because that sensitization might not be against the donor. On the other hand, now I believe probably that we are in a paradigm shift of how we interpret the cross-match. Is every cross-match contraindication? I think we have to look at it from different direction, which is, before, a lot of people saying that the cross-match is contraindication. Positive cross-match, I think it could help, as we in our institution, it is for risk individualization, especially if the institution have the weapons to remove that antibody and make that positive to negative. Regardless, of course, there is, in this scenario, there is something that we have to mention, which is benefits versus risk. Still, the patient might be transplanted, but still there might be a risk since he or she is primarily positive CDC. So it's not mainly now for us a contraindication for transplant, but it is help us to how we going to categorize or individualize that patients. And we individualize every single patient who come to our program by 3 different categories: low risk, intermediate risk, high risk. Every category has its own immune profile. So risk individualization, high risk patients is the patient whom demonstrate donor specific antibody, but with positive CDC cross-match and positive flow cross-match. This is very high risk category. If the physician interested to transplant that patient, he definitely will use all of his weapons, all of his tools to eradicate this. And his target is remove this donor specific antibody. Once he removes that, both of those going to be negative. It's going to be it is a challenge. Not every patient behave the same. Another category is intermediate risk, in which the patient have donor specific antibody, but his CDC, which is very low titer antibody, which is not sensitive, is negative, and the flow is positive. This tell you that this antibody that he has is not really that very strong. So maybe the physician will use immunosuppressant or IVIG, but IVIG or whatever plasmapheresis, this is his decision as a clinician, but not as strong as the high risk category. In the last category, still also you must see a patient who have donor specific antibody but very, very low. That antibody might not be even to kill the cells or make it positive. That's a risk, that's a low risk. The physician has its own scenario of medication, so we have to individualize the patient. I think by implementation this, we will be able to transplant more patients. We will be able to transplant more high risk patients with the good results. And in addition, we have to back, I think this question late came, when we need to do a cross-match pre-transplant. Do we need to do it with everyone? I'm not talking about one day before the surgery, but I'm talking about once the patient join the program or become a candidate. We need to do antibody screen, or we need to see if the patient is sensitized. If the patient is sensitized by very, very sensitive assay, do you need to bring the donor? Do you need to draw the donor? And do perform initial cross-match with 6 hours incubated using your people and manpower and the cost? Because if there is no antibody, then definitely the cross-match is negative. But that assay or antibody screening methodology must be very, very sensitive in order to assure there is no anti-HLA antibody. And also, if you screen the patient and you know up front that he or she has donor-specific antibody, then it is must to do initial cross-match to categorize the patients, which category he is belong to, before we deny that patient, in order to give the physician to decide which type of immunosuppression he will give or desensitization he will shoot. If you don't have, as I mentioned, no DSA, final cross-match one day before the surgery might be really enough. Virtual cross-match is not a new technique. It is not a new concept. It is basically back again because of the tools that we have. Single antigen by solid phase assay enable us excellent to do virtual cross-match. And probably I have not more than few slides more. We'll show you how does virtual cross-match enable us to work properly and also reduce the cost and implement lean methodology in the transplant laboratory. Probably, as you see, if we have this patient has this antibody and he has two donors. He has antibody anti-A11 against this donor, but nothing with this. Up front, you can select this without getting surprises in the last moment. Okay, and also vice versa. If let's say that this is a deceased donor transplant, not living related, if we have a donor who is potential donor cadaver, example, he came to us and we did HLA typing, we can eliminate all of our patients come to the institution because we have a precise antibody screening and we will know prior organ harvest that will definitely will let even the Scott do their job properly. They don't have to send us the organ. They might give us to another organ. They don't have to give us that organ. They can send that organ to another institution that might be much appropriate than ours. In this scenario, that's what we apply. Most of the patients come to our institution from around the kingdom. They come regularly to do their PRA, or they come once the coordinator called them to come, they have a potential donor. So they come to be tested. In addition, if you think we change our protocol in which we don't wait till the organ harvested. We do primitive job in which the coordinator do a great job in which they bring blood prior harvest that we enable us to do HLA typing and do virtual cross-match among all of our patients. And we will be ahead of the harvest or ahead of the surgeons when he do the harvest. We will be able to know who is highly sensitized from our waiting list that he will be most likely going to have negative. And our target in deceased donor transplant, of course, if we transplant highly sensitized patient who has been in the waiting list, that's really most successfully, and that's really what we are looking for. And also, if we think about it, in this one, this disappointing. Instead of bringing 6 patients waiting in the ER and doing in the test and at the end of midnight or in the morning after 6 hours coming to them and say to them, I'm sorry, go back home, you need to come another time. It is really painful emotionally. It is really painful to them because they came from all around the kingdom, a lot of cost and the government and the patient hassle and also in the hospital resources. But by applying virtual cross-match, it will definitely reduce the cost. It will definitely give the proper organ to the proper recipient. And also will enable us to transplant the highly sensitized patient. And I think once we did this type of phenomenon, we did transplant highly sensitized patients. And also this one, not only the benefits of it on kidney transplant, the benefit of it in lung transplant that we do, in heart transplant, in which the ischemia time of those organs, like the cardiovascular organs, like the lung and the heart, is very short, 4 hours. Impossible that we can finish the test in 4 hours. So that's why most of the time now we do the cross-match prior harvest using the blood, not the lymph node and spleen, especially if we have heart and lung, in which they can transplant immediately with very low ischemia time. And also the renal people, they have a luxury of time to do whatever. If they need to desensitize, they can. And also they will, by doing the test, by doing the virtual cross-match, even from the clinical side, they will decide the proper organ to be harvested. So we will be able to do the typing in a timely manner. The ischemia time will be decreased, reduce unnecessary shipment of organs. If that virtual cross-match is positive with all of our patients, they don't have to bring us that donor. They can send it wherever they need to do. And also the basic requirements, it is as it is benefits, as it is need a lot of cost also. You need the laboratory in order to implement this and achieve that. Also routine patients antibody screening and precisely and continuously frequently need to be done. And also HLA typing of all loci, A, B, C, D, R, D, Q. A lot of people in the previous literature is talking about A, B, D, R only, but still we might see patient reject the organ due to C, reject the organ due to DQ. So we need to type the donor across the board for all the loci, because all of the loci should be well respected, because all of those might lead to a rejection or positive cross-match. extensive identifications. The laboratory, in order to implement this, definitely should have really good technology and a precise interpretation to not get surprises in the last minute if you have a cadaver. And I would like to conclude by acknowledge all of our colleagues in the laboratory, every one of them, for their dedication and excellent effort they are doing, and without them we will not be succeed definitely. Thank you very much.
Thank you very much, Fadi. May I invite Maha and Mohib, please, to join me here on the podium. We have the discussion part now. It's for the next 20 minutes. Please, I would like to encourage all of you to ask questions. In fact, we will welcome any kind of question. We know this might be some difficult concepts to some of you about it, but we encourage and we ask you, please, to participate in the discussion part. And as I promised you, the afternoon part will be much more interactive with discussion and voting devices. So any questions that pertains to the 3 or 4 lectures presented this morning, please just identify yourself and ask the question. Please, yeah. Assalamu alaikum.
Okay. If you are desensitizing a patient, example, with IVIG, you know that this IVIG is pulled from different people. IVIG non-specifically will bind to the cells. If you do flow cross-match, the secondary antibody will not recognize, is this IVIG that you add already, that you gave already the patient? The secondary antibody will not identify, is this HLA antibody or not? So it will bind definitely, it will show you positive, because that IVIG is already bind to the cells, already block the cells. This is one of the things. So and in addition, the patient will be fully with IVIG in his body. So IVIG is antibody. So you are not sure really cross-matching that IVIG that you already give and artificially sensitized from outside, or the natural antibody from the patients. This is one of the things. Another thing is rituximab, of course. If you give induction therapy for the B lymphocyte, it will bind to the B lymphocyte definitely, okay, which is the rituximab. And the flow cross-match, it will consider also as antibody, okay. So the secondary antibody will bind to the rituximab. You're going to see positive. You will not be able to know, is this positivity due to the rituximab that you as a clinician already gave, or due to the primary antibody, unless the laboratory have the tools to remove that rituximab totally from before doing the assay. This is the 2 desensitization regimen that you might use. Sorry.
The methodology of Crossmatch, you're talking about CDC?
No, I'm talking about flow. Yeah.
This will affect the flow?
Yeah.
So the final flow cross-match will be affected by the presence of the IVIG in the body?
Definitely, and rituximab.
And the lab will be able to tell you?
The best method to decide to transplant or not to transplant might not be depend on cross-match, but you should depend on solid phase assay, because that one might be less affected with IVIG and rituximab. So probably you can make your decision based on single antigen that you have after desensitization, not on cross-match.
So the lab will be able to differentiate
between
whether this cross-match is positive because the patient is still positive, or whether this cross-match is positive because of this.
If you tell us that he is under rituximab,
yeah,
what we're going to tell you, that our result is positive due to your medication, but we're going to do immediately solid phase assay, which is single antigen, but we're going to tell you that the donor-specific antibody for that donor that you are desensitizing that patient for is positive. So you need to change your vision from cross-match to solid phase assay.
Thank you.
Yeah, thank you.
Thank you very much. Yes, please, at the front. Please.
I'm coming from a different school, from the Scandinavian school, and I told
Okay.
It's very sensitive, and I don't even for any restrictions. Or MFI not just MFI 500 units.
Cool.
Not just 2,000 units, 3,000 units. But a positive cross-match, a positive flow, this is, I will consider it as a contraindication. Unless I'm going to Luminex, unless I'm running after specificity. Can you comment on
what do you mean specificity?
If I want to know that the specific, if it's a positive cross-match, I'm running after specific antigens that the donor has, that the donor has for the recipient. A positive cross-match,
yeah.
Is a contraindication.
It's true.
I'm putting the risk through the value of 500 or 1,000 or 10,000 in the Luminex. I'm only interested if it's a positive cross-match, and I will be interested to use the Luminex only in case that I'm interested to know the specificity of the antibody.
You are right, Dr. Jihad, but you are talking about positive cross-match by CDC and flow, or by CDC, not flow. If you are talking about positive CDC, yes, it is contraindication, which indicate presence of a lot of antibodies against donor antigens. But if you have CDC is negative, flow cross-match positive, and now it is not contraindication, yes, the graft survival if you go against flow positive is less, but it is not contraindication. You can desensitize. In this case, you maybe need to get the help of the Luminex technology to tell you if your desensitization is working to reduce the MFI, although it's just arbitrary number, or the titer to start with is not really high to bother to do desensitization. So I think the more tools you have, the better decision you will make.
Afwan, Dr. J, if I elaborate, if you will ignore and solid phase assay, and we mentioned that is meaningless, even the MFI, and depend on CDC by CTA, by serology, we're going to be in a hell, because CDC or cytotoxic antibody by that solid phase might not be really sensitive to detect weak antibody. And if we transplant the patients without giving the clinician a full picture, might be really, I think, contraindication.
Very good. Thank you. Next. Yeah, at the back, please. The back.
Hello, Awad Osman, King Fahd Medical City.
Can you turn on the microphone, please? Just turn it on. Microphone works much better once you turn them on, yeah. Go ahead.
Just my question about Luminex, because sometimes just we need to do like HLA screening, and we have to report PRA. But some the Luminex is very sensitive, and it is very, very, very difficult to determine the cutoff. Which cutoff you can to adjust your PRA, and then you can decide the result is. Could you tell us about your experience in King Faisal Medical City, about King Faisal Specialist Hospital, about your adjusting the cutoff for HLA antibodies? Thanks.
When you talk about single antigen or antibody testing by Luminex, it's very important to have your own, or you determine your own cutoff. I mean by cutoff, if you have donor-specific antibody and the MFI is 2,000 MFI, some people, they consider this a positive, and maybe they don't want to do cross-match, or they don't want to do transplant against someone who has 2,000 MFI. But some other, they say, no, I will raise it to 4,000. And why they have different cutoffs is this 4,000 MFI, when you do cross-match, this patient with his donor who carry that particular antigen, which we call it unacceptable mismatch, will it give you positive cross-match? If it does give you positive cross-match, then your cutoff is really good. But if you put your cross-match or a cutoff 2,000, which is low for many people, and you do cross-match, it will be negative. So what's determined your cutoff is your cross-match results. If the cross-match results, especially by CDC, which the physician really like, And why they like it? Because it is really, really unlikely to have hyperacute rejection when the CDC is negative, period. And as Dr. Mshari mentioned, it has been in use for 30 years and still people sticking to it, not because it is superior, no, but that particular technique proved that good correlation with hyperacute rejection. No one physician want to go with the possibility of hyperacute rejection. To guarantee that, if flow is not of a big help. But if I tell Dr. Limshari that this patient is CDC negative, he will be happy to do, even if the Dominic's DSA is high, he will use his arsenal to reduce it, but he will go for transplantation. If that particular patient has no alternative donor or he couldn't find in the paired kidney exchange program we have. Otherwise, if it is CDC positive, he will try, if it is not very high titer, to make it negative, then proceed to transplant. But no one would like to go with high CDC cross-match.
Just speaking about different here in because some laboratories doesn't running like cross-match because they don't serve like organ transplant solid. And in this case, some patient, they send them for just HLA antibodies, and you have to determine the BRA. My question, because I got like so many different results from so many laboratory, and each one has his own procedure for adjusting the cutoff to determine whether it's positive or negative. My question is, your experience here, because you sharing like HLA antibody screening and specific and also cross-match. But for the laboratories that doesn't run the cross-match, how can they adjust this cutoff?
It is very challenging. We have been doing Luminix for 5-6 years now. It is challenging not just to us, for everybody in the field. The problem of Luminix, the number of MFI is arbitrary. So it is not standardized. This is one of the major drawbacks of Luminix, which we didn't mention here because it's beyond the scope of the presentation. But it is very challenging. If I give you a sample that I run myself, and I found it is 5,000 MFI, you might find it 8,000 or 9, or you might have it 3. And none of us is wrong. This is the drawback of this procedure. That's why when we look at a case for transplantation, we look at all the pieces we have, previous antibody testing, current cross-match results, previous transplantation history, transfusion, everything, name it. Then we can make the best decision.
Very good, thank you. I would like questions from ladies and questions to Maha, please. Yeah.
Ladies to Maha.
Dr. Iban from the MEM Regional Lab. I have one question for Dr. Muhib. How can you interpret the result of BRA if you have a high negative control value, more than 1,000 MFI?
If you have, which is something common we see from time to time, if you are talking about Luminix, maybe the patient he has an antibody against the beads itself, not the antigen on the bead. For our lab, we are equipped to absorb those antibodies that is against the beads itself. We absorb the antibody, we treat the serum with these beads, then we absorb the antibodies, and the treated serum, we use it for the actual testing, and the background will be down, and you will get acceptable results.
Okay. And one question for the Fadi, the value of Brunet's technique in cross-match, again.
Increase the sensitivity.
Of what?
Period. Because you are, without doing Brunet's, if you do T cell and B cell, you will see a lot of false positive because of non-specific binding. If you give Brunet's to the cells, you are blocking those receptors on the B cells. Once you take it out, you're just leaving your HLA exposed. So once that antibody find its loved antigen, it will bind to. But if you did not treat yourself to those with Brunet's, then definitely will be non-specific binding. So Brunet's is definitely tremendously improved, I say.
In both, if the patient use rituximab or IV?
No, that's something else. Rituximab is different scenario.
Okay,
yeah.
Thank you.
Very good. More questions? Yes, please.
Good evening, everyone. Thanks for impressive talks. I just have one comment or question regarding the determination of the cutoff. Again, it's for Dr. Muib. First, how you select or what's the criteria of selecting the serum for adjusting the cutoff. The second is how frequent you will revalidate your cutoff for Luminix.
If you are talking about single antigen, if we have done, say, 30 or 40 different single antigens and all those patients went to a cross-match, we put categories as Fadi showed you here, say from up to 4,000, 4,000 to 6,000, 6,000 to 10,000. We see which of these categories, again, if we consider it low, medium, high, which of these categories will give us a positive cross-match. We want to know what is the MFI that will result in cross-match positive. Here, not just cross-match one technique. What cutoff will give us flow cross-match? What cutoff will give us CDC cross-match? Because you need really a lot of antibodies for the CDC cross-match to be positive. Much less antibodies you need to give you positive flow cross-match. So in our lab, we have two cutoffs that we did in our lab, and it will give us positive cross-match, whether flow or CDC. That doesn't mean always it will work, but most of the time. For example, if Fadi or Maha or Dr. Limshari gave me or I gave him, he will tell me, okay, you don't need to do CDC cross-match because the MFI is low. We know in our lab this will be negative. Sometimes if it is not for transplant, we don't do it, but for a transplant, we don't spare anything but to guarantee that there is no positive